Welcome, everybody. Thank you for joining us for today's presentation titled Lung Cancer Gene Fusion Assays using NanoString nCounter technology. It is my pleasure to introduce to you Dr. Noemi Reguart. Dr. Noemi Reguart is a medical oncologist from the Department of Medical Oncology at Hospital Clinic here in Barcelona, and she's also leading the lung cancer unit at our hospital. For a complete biography on our speaker, please visit the tab at the top of your screen. If any questions arise during the presentation, we encourage you to submit them in the Q&A box, and our speaker will respond back to you by email. So please join me in welcoming Dr. Noemi Reguart. I will now turn the presentation over to her.
Hello, thank you so much for this kind invitation to participate in this virtual conference hosted by NanoString. It's a pleasure to be here. My name is Noemi Reguart, and I'm going to talk about our experience in lung cancer gene fusion detection by using NanoString nCounter technology. Here are my personal disclosures. So here's the outline of my presentation. We are going to put in perspective which are the current needs in lung cancer management. We are going to go through the opportunities that nCounter provides us in terms of molecular lung cancer detection. And we are going to go through our key results by ending up by showing how the data has impacted in the clinical outcomes of our patients. So let's start with the first part, which are the current needs in lung cancer. So during the last year, we have witnessed dramatic changes in the way we are approaching lung cancer therapy. We have moved from an histology-based therapeutic strategy to a molecular-driven one. And among the different subsets of histology, adenocarcinoma and squamous cell carcinoma, adenocarcinoma is the one that has benefit most from these targeted approaches, because around 60% of adenocarcinoma of the lung harbor oncogenic driven alterations with potential for target inhibitors. So the emergence of targeted therapies have revolutionized the landscape of treatment for lung cancer along with immunotherapy. And currently, the detection of these gene alterations is very important because they are going to tell us which patients can be which patients can receive an individualized treatment with a targeted approach. This is why molecular testing has been introduced in the routine workup of our lung cancer patients at diagnose, along with other imaging techniques or histology techniques. So this is an important step at diagnose in all patients with non-squamous advanced non-small cell lung cancer patients. And because targeted therapies are very important, several molecular guidelines are today are recommending the identification of four leading oncogenes. Those are EGFR and BRAF mutations and 2 gene fusions, ALK and ROS, while they recommend to use an optional test, a list of other genes, which are important because they are likely going to approach clinical practice in the future. Those include, for example, gene fusions in RET and NTRK or mutations in MET. Among these genetic alterations in lung cancer, there are several. Some of them are point mutations at DNA, but others are gene fusions. And among all these gene fusions, ALK, ROS1, RET, and NTRK, the standalone techniques for detections FDA approved right now are FISH and immunohistochemistry. However, we are facing now a new necessity. That means that we are not just need to test for one gene, for ALK, for ROS, or for RET, but we have to test for several genes, around seven 6 genes that can receive targeted therapies. So this is why multiplex marker molecular testing with techniques such as NGS, or in this case NanoString, can be useful and are being more frequently incorporated in routine clinical practice. So let's move to the other part, which are the opportunities that nCounter offers for gene driver detection in lung cancer. So I'm going to just give an overview of nCounter technology, because probably other speakers are going to give more data about it. But nCounter technology is transcriptomic system analysis, which can analyze several genes in one single tube. It doesn't need any enzymatic reactions, and it works by using one color code barcode, which allowed for digital quantification. This is the methodology and workflow for NanoString analysis. I have to say that this is a very straightforward technique, semi-automatic. It's flexible in terms of sample input. It means that we can use several samples, formaldehyde, fixed paraffin embedded sample, or even cell blocks. It has a really fast turnaround. We have the results in 3 days, which is very important when we are talking about advanced lung cancer patients, which need to have the results very fast to start treatment as soon as possible, and it's low hands-on time. NanoString uses 2 approaches for the detection of gene fusions that I remember I said that are very common in lung cancer, oncogenic alterations. And the NanoString uses 2 techniques. The first one is a fusion target specific assay, and the second one, and very useful one, is a 3-5' imbalance assay. By designing a specific capture and report probes that are located upstream and downstream of the fusion junction, the technique can detect the imbalance, the ratio imbalance between both probes, and detect which patients have a breakpoint site and which samples are, or which tumors have a gene rearrangement. This is our nCounter experience, and I like this slide because it seems that we started yesterday, but we started back 6 years now. We started in 2014, and Dr. Brandt kindly invited to test it for lung cancer patients, so I'm very glad he gave us this opportunity. So we started in 2014, and since then we have moved forward. We first retrospectively evaluated the technique in advanced lung cancer patients, and our last work that has been to prospectively evaluate the clinical usefulness in clinical practice. So let's start with our retrospective validation that was published in 2017 in Clinical Chemistry journal. So in here we started designing our own custom designed code tag set which included 51 probes that were designed to identify several variants for gene fusions at ALK, ROS1, and RET. Here is the patient cohort of our study. It included a total, sorry, I don't see it very well, but it included a total of 98 patients. This was a very enriched population set of patients because the majority were positive for ALK, ROS, or RET fusions. And so, sorry, I go back. And we corroborate the results with the other approved techniques for detection, which are FISH and immunohistochemistry. So we first evaluate which were the sample requirements for threshold evaluation with NanoString, and we we observed that, as you can see here, as for immunohistochemistry and FISH, the cell number is required. It's around 50 to 100 tumor cells. For NanoString, as well for other multiplexed techniques such next-generation sequencing, the number of cells required are higher, around 600 or 1,000 tumor cells. And regarding RNA, which is very important for NanoString nCounter detection, the optimum minimum amount of RNA we identified was 200 nanograms. However, I want to point out that we had several samples with a minimum amount of 25 nanograms that also resulted positive for gene fusion detections. Here's a representation of our results. I'm not going to go through each fusion, but it's just to show that the NanoString could identify ALK, ROS, and RET positive fusion alterations. And you can see here how nicely the technique can identify the different partners or variants associated for each fusion gene. Then, importantly, we aimed to see which was our reproducibility of data by comparing it with the standard techniques, FISH and immunohistochemistry. And as you can see here, the concordance of NanoString with immunohistochemistry was very high, almost equal, around here, 96%. And very important, the sensitivity for the detection of these gene fusions compared to FISH was higher with NanoString. Indeed, among the 11 cases that were positive for FISH, for the 11 discordant cases with FISH and NanoString, we could corroborate that 10 of these negative FISH negative samples were positive with immunohistochemistry. So we could recover 10 patients that otherwise could not have been identified by the standard FISH technique. We then aim to prospectively evaluate the NanoString technology in the routine workup of advanced non-small cell lung cancer patients. And to do so, we decided to extend our tag set, and we created or designed a second code set with 72 probes that included other genes, among them NTRK and MET exon 14 skipping mutations, which are important genes in which several targeted therapies are having really nice results and are going to be soon incorporated in clinical practice. So this is what we have done till now. We have evaluated a lot of samples with NanoString, a total of 470 samples for a total of 405 patients with advanced non-small cell lung cancer. And important here to show how only 5% of those patients had insufficient material for detection, which is a very low rate. And this is very important because metastatic advanced non-small cell lung cancer patients normally have very low material, which is obtained from small biopsy needle aspirations. And here I wanted to put you, it's not going to go to the specifically detail. I just wanted to show you the normalized ratio for the imbalance detection for each of the gene fusions you have here for RET, for NTRK, for ROS, and for ALK fusion genes. And as you can see here, for some genes, the positivity of detection was seen very nicely. The ratio of the imbalance was very differentiated to other negative or wild type patients. And a few samples, mainly in those patients having ALK fusions and ROS fusions, as you can see here, the positive cases were really close to the threshold for positivity. This is why we decided to do our own algorithm for validating those cases that were very close to the threshold, and we consider them equivocal. So right now, for negative patients with NanoString, we are not doing further testing. For those patients that are equivocal, we are validating them with an orthogonal FISH or immunohistochemistry testing, and we are also validating the positive cases as for exploratory analysis for all positive cases with NanoString. And here also a nice picture. We have had everything. We have had patients detected by nCounter with ALK, which is one of the most common gene fusions, but we also have detected gene fusions that are found in less than 1% of patients. We have had RET positive patients. Here you can see nicely the imbalance of the 3' 5' prof ratio, and here you can see this is the positivity or the signal for the specific variant. We also have had patients with NTRK fusion. We have one patient, but it's our NTRK positive case, and we also have had several ROS positive cases. And the important thing is that all these patients have been detected upfront and diagnosed, which means that you can give the best opportunity at the beginning of treatment. And nCounter met exon 14 skipping. It's another important gene alteration that it's gaining importance in lung cancer because there are several drugs, capmatinib, tepotinib, savolitinib, that are getting really good results. This is a technique which has no standard for detection, unlike or ROS, and while recommendations are using RT-PCR or NGS. So I meant to see if by using the same approach, by using different barcodes and probes, by binding them to the exon 13, exon 14, and exon 15 from the gene, we could identify those patients that had, or those tumors that had the skipping at exon 14 with the same approach, seeing if we could see an imbalance between those patients with a complete gene or those patients that had an RNA splicing, which is what is giving the oncogenicity. And we did it, and the results are fantastic. We have identified several exon 14 skipping results. As you can see here, the ratios changes completely, and you specifically identify the RNA which is spliced, and we have confirmed all the cases with RT-PCR and with sequencing. And this is one of the most important slides of my presentations. Since June 2007 to April 2020, NanoString has been able to identify 9% of druggable gene alterations. Among the most common one, ALK, we have identified 11 patients, which is almost 4% of incidence in our population of patients, which is very similar to other Eastern countries. ROS, RET, NTRK are really rare alterations, but well, if you put them together, you see that we have had 5 patients that have been able to receive targeted therapies, specific targeted therapies for this alteration. And one of the most important things is MET exon 14 alterations. We identify a 4% incidence in our patients, which is higher than the ALK translocation, and puts it as one of the major or most important targeted alterations that can soon be incorporated in the clinical practice. And this is my last part, the last part of my presentation. One of the important things was to demonstrate which was the usefulness of nCounter in lung cancer in terms of outcomes. And I'm glad to share with you that 1 week ago, we had our second paper accepted. It's open access, and you can find it in Cancers. And it was the idea here was, if we wanted to use NanoString, we had to put NanoString together with the other technique, which is DNA, for the detection of all genetic alterations, not only in the RNA, but also in DNA. So, and this is how we are handling right now in our hospital the identification or the molecular characterization for lung cancer patients. We are using in tissue, we are using next generation sequencing on combine to identify alterations that DNA mutations, and we are using nCounter for the identification of gene fusion and MET exon 14 skipping mutations. And it was very important to create our own flow chart for paraffin tissue processing. And this is very important because I mentioned it before, tissue samples in lung cancer are scarce and very tiny. So we have to handle it in a very optimal way, tissue samples. And as you can see here, the slides section for the nCounter are sectioned up front, together with the immunohistochemistry diagnose techniques at the beginning of the cutting of the formaldehyde-fixed paraffin-embedded tumor. And this is the cohort of patients we evaluated. We were able to evaluate a total of 172 patients that had results for DNA and RNA, but the total cohort, for some patients, we could not get information with RNA, and we rescued them with other techniques, immunohistochemistry or FIS, and the total cohort included 121 patients. And this is very nice illustration of the computational plot, how our data reproduce similarly to other TCGA publication previously. Those are only advanced non-small cell lung cancer patients. In here on your left, you can see the gene alterations, and the columns are the different patients that are grouped by gene alteration, as you can see here. And it's very nice because you can see how the different oncogenic alterations are exclusive. It means that the tumor is only dependent on one alteration. So once you have an EGFR mutation, you don't have an ALK fusion or a ROS fusion. And this data is very important because also corroborate that our results are good. And here are the pies for the incidence of our population of patients in hospital clinic for the total number of 191 patients. You can see here the most common gene alteration, of course, was KRAS, which is the most common because it's the most common in smokers, in patients with smoking habits. But those here are with these different color are the ones that we are most proud about, which are all the genetic alterations that we were able to identify with NanoString, and that made that the total number of patients with an oncogenic driver in our population rise to 68%. And here you can see how nicely the different colors and the incidence of the different alterations change according to smoking habits and gender. And this is my last slide, and this is one of the most important of my presentation, which was to demonstrate that if we gave specific targeted therapies to these patients with specific genetic alterations identified either with NanoString or with NGS, DNA NGS, we could improve overall survival. It means that it was worth it to give specific targeted approaches to those patients. And you can see here on your right how in red, how those patients that had harbor an oncogenic driver that were treated with a specific targeted therapy had an significantly improved overall survival for more than 2 years as compared to those patients with driver or no target therapy, with no targeted therapy, or those patients with no driver. And with that, I want to conclude my presentation. I want to thank Dr. Brad for his continued support, all the oncology, thoracic oncology unit, and my collaborators in the clinic and in the lab. I also want to thank the Spanish Ministry of Health for the grant they provide me to do all this research, and also our collaborators in Pangea de Cheus. Thank you so much for your attention.
So, Dr. Reguart, let me ask a few questions. One particular question would be, how old can the FFPE tissue blocks be? Is there an expiration date past which the quality of RNA is no longer good for use on the nCounter, in your experience?
So this is a very important question that often comes out, because when we are working with RNA, normally we have in mind that RNA is easily degraded. And when we are using really old paraffin, formaldehyde fixed paraffin embedded tissues that have been stored for a long time, that the RNA is not going to be good enough. Quality is not going to be good enough for NanoString. But this is not, NanoString, it doesn't use amplification of the RNA for testing. It's counting, color code counting for digital analysis. So it doesn't need any enzymatic reaction. And in our experience, we have seen that paraffin blocks really old as 15 years are good enough for doing the testing. So we don't have any expiry date for testing with NanoString. We always try it, and the majority of times we have got good results. I could say that it's more important the quantity, the amount of the RNA you have in there, rather than the age of this paraffin embedded tissue block.
I think another question that I was really intrigued about is, can you repeat, or can you tell us what is the minimum RNA input required for the particular assay you're using in the clinic?
As I mentioned before, I think the minimum of RNA, yes, is important. It's important that when the sample is taken, as I shown at the beginning, this flow chart, which is always implemented in the pathology at the beginning of the diagnosis and the tissue management of lung cancer patients. It's very important to check if there are enough cells for testing not only for NanoString but also for NGS, because the requirements are quite similar. The total number of samples we have seen that a total enriched total number of tumor sample of 600 or 1,000, it's enough. And if we talk about the input, RNA input, the optimum it's 200 nanograms to be sure that you are going to have results. But we have got also positive cases with a minimum of 25 nanograms of RNA, which is a very low amount of RNA. So I could say that in daily clinic practice, I would say if you have enough tumor cells, go ahead. Don't look at the age of the paraffin embedded tumor sample, and don't look at the quantity of RNA, because you would get surprised how nicely NanoString performs with very small amounts of RNA.
In addition, what do you prioritize if the material in the sample is not enough for both DNA and RNA analysis? What would be your priority for lung cancer patients today?
Well, this is a very good question. It depends. Right now, with the COVID, I have to say that we are prioritizing RNA and NanoString, because we are no longer able to do oncomine, because the pathology department is really busy doing RT-PCR for COVID. So we are very, very lucky that we have NanoString at least to identify the other bunch of genes. But if we do have a tumor that have very small amount of tissue samples, normally we prioritize NanoString, but not because the genes are more important or less important. It's because, as I showed you before, NanoString slides have been incorporated at the beginning of the tissue handling or processing of the samples, because the slides for NanoString are followed to those used for diagnose immunohistochemistry, and after that we change, and then we start doing all the sectioning for Oncomine. And for EGFR detection, for example, we can use other blood techniques such as COVADs, and normally we prefer to go for NanoString in tissue with PD-L1 at the beginning of the diagnostic workup, and then continue with the Oncomine. If we do not have enough samples needed for Oncomine, DNA, or RNA, then we have the CLIMB study, which is a blood sampling NGS study in our center, in which we are able to do NGS in blood.
Another question is, how does the nCounter perform compared to other techniques that are also implemented today, such as RT-PCR or next-generation sequencing for the detection of the MET skipping mutation? What is your experience, and what are the differences among the different assays?
This is a good question, and there is very little data about it. And we are our third paper right now ongoing, and we already have it written. So we hope it's going to be our third paper with NanoString. It performs very, very well. And when we have our paper out, you will see really nice data, because NanoString can give further information beyond the skipping exon 14 skipping alteration about the amplification or the expression of the gene. And those have been biomarkers that have not had really great success when exploring targeted approaches, but maybe it was because we were not using the optimal biomarkers. So I cannot talk more about that, but I think our data is going to give a lot more information about this novel gene, which is MET exon 14 skipping. So with my presentation, I have shown you how NanoString performed really nicely to identify several gene fusions and also novel gene alterations such as NTRK, such as MET exon 14 skipping mutation, which are very important currently to prioritize targeted therapies in these advanced non-small cell lung cancer patients, which have really poor prognostics and in which targeted therapies can improve the outcomes. NanoString is a really high throughput technique. The samples we are using can be very old. You can use it with very small amounts of RNA. I mean, it's very useful to be used at least in lung cancer, because these are the perfect conditions that we need for our tumor samples. And we hope in the future, we have been able also to incorporate NanoString in the routine workup in our hospital. I'm very glad of that. And I think that our final data and clinical data corroborate that we have really good results, and NanoString is a really useful technology to be used as well as other DNA NGS techniques in the management of the diagnostic management of solid tumors. And thank you so much for your attention.